7 o'clock. 7 o'clock. So I'm going to get started on my introduction to bone physiology. And this is basically a continuation of the lecture that I gave a couple of weeks ago. And so this is one of the buildings on our campus, and I'm in the orthopedic department office, and that would be right about there. So that's where I'm sitting right now. So there are obviously congenital bone diseases, and then there are acquired bone diseases. And there are more than just these four, but these are the four that I'm going to talk about: osteoporosis, osteomalacia, which is what we call rickets in children, Paget's disease, and there's a Paget's disease of the breast. I should have said Paget's disease of bone, and then hyperparathyroidism. So let's go over some basic facts about osteoporosis. As the name implies, the bone is too porous. It is not as dense as it should be. And so there is less than a normal amount of bone, but the bone that's present is sufficiently mineralized. So the mineral to osteoid ratio is normal, and osteoid means unmineralized bone. So with osteoporosis, the mineral to osteo ratio is normal, but that's not true for osteomalacia. The normal amount of bone, in normal circumstances, our bone mass peaks, plateaus at around 20 or 25 to 30 years of age, and then around 40 years of age, just because of the normal processes of aging, we tend to lose bone mass. And part of the reason, a big part of the reason, is that not enough osteoblasts are formed, and the osteoblasts that are present are not functioning as well as, or as efficiently as they used to. And also growth factors, they tend to lose their potency in the process of stimulating osteoblasts. So those are sort of the physiologic reasons, excuse me, but that's not the only, those are not the only factors in why we tend to develop osteoporosis. So other things that are under our control are things like physical activity. As we get older, we tend to be less physically active, and so there's less stimulus for the bone to stay strong. We think of exercise as exercising our muscles, but we also should be aware that exercise stimulates bones to be strong, not just muscles to be strong. Also, we tend to spend less time in the sunlight, and so we have less vitamin D production. And that is actually more of a problem with osteomalacia than osteopenia, but it's a problem for both. And then in older people, sometimes they don't eat very nutritious meals. So that's another factor. So you might think of osteoporosis as being mainly a problem with women, and that it's true. And the reason for that is that menopause tends to cause bone mass to decrease. And that's because there's less estrogen. And I have a repeat slide from 2 weeks ago in a minute that I'll go over this. So there's less estrogen when women go into menopause, and with less estrogen, there's less inhibition of the rank ligand. Therefore, more macrophages become osteoclasts, and more osteoclasts result in more resorption of bone. So here's a little pop quiz. So what's the chief mechanism involved in the osteoporotic effects? It's not decreased appetite. Oh, by the way, this is a question for our students here in Oklahoma-Sity, so I just put it in. So it's not a decreased appetite for milk products. This is not a good answer because in menopause, there's not increased estrogen, there's decreased estrogen. And so that's one reason that's a bad answer. And then also estrogen does not suppress osteoblasts. So then the next answer is decreased estrogen. Okay, so that part of the answer is true because there is decreased estrogen during menopause. So it says decreased estrogen suppression of osteoprogenerin. Well, estrogen does not suppress osteoprogenerin. And then the final answer is decreased suppression of osteoclasts. So that's the correct answer. Remember, estrogen inhibits the development of osteoclasts. When estrogen is in short supply, this inhibitory effect on osteoclastic development is decreased. So there are two main categories of osteoporosis. One is primary osteoporosis. This is what develops naturally with age. And then there's secondary osteoporosis. It means that osteoporosis develops from an underlying underlying disorder. But this becomes very complicated because secondary osteoporosis kind of blends into what at least we used to call renal osteodystrophy. That's a subject that the nephrologist and the endocrinologist know a lot more about than I do. So I'm going to cover this in very basic terms. So with regards to primary osteoporosis, remember that the bone reaches plateau, the bone mass reaches a plateau at about 25 to 30 years of age. And around 40, the bone mass tends to decline, especially in Asian women and Caucasian women, and in women who weigh less than about 57 kilograms. As we age, the osteoblastic formation and the osteoblastic activity declines because of basically two things. And there's a slide, the next slide is a repeat slide from a couple of weeks ago, and I'll refer to that here in a second. So there's a dysregulation of the interactions of rank, and I can't even remember exactly what rank stands for, reactive activator of nuclear kappa or something like that, and the rank ligand and OPG. So there's a dysregulation of those things. And then there's a decreased potency of the growth factors. So I'm going to skip ahead to the next slide to talk about those things here in a second. Okay, so, and I always forget. Okay, so these are the things that promote the development of osteoblasts. So there's decreased potency of those things. And then there's this dysregulation between these. Remember that the rank ligand promotes the development of osteoclasts from macrophages, and it also stimulates these osteoclasts to eat bone. And OPG, osteoprotegerin, blocks the effects of the rank ligand. So as we get older, there's a dysregulation of this process, and there's decreased potency, decreased potency of these growth factors, these factors rather that promote the development of the osteoblast. And so I didn't develop this slide. I don't know who did. It was given to me by one of the physiologists. So I'm not sure exactly why these three things are highlighted. I think all of these things, I know all of these things promote the development of the osteoblast. So let's go back to the previous slide. So again, there's a dysregulation of the rank ligand and OPG, and there's decreased potency of those growth factors that I just pointed to. So the effect is that there's a decrease in the bone mass, which averages about 3% per decade in the cortical bone, also known as lamellar bone. This is the hard bone. And then there's about a 7 to 11% per decade decrease in the mass of the cancellous bone, or you can call it trabecular bone or spongy bone if you want to. Okay, and on this slide, this makes it look like estrogen is physically blocking the osteoclast, but that's not actually how it happens. Estrogen somehow enhances the effect of OPG and probably does other things too. But keep in mind that estrogen tends to decrease the development of osteoclasts, and it decreases the activity of the osteoclast. And again, I think it's because it enhances the OPG. So primary osteoporosis, in other words, osteoporosis that's not based on some sort of underlying medical problem, is divided into basically two parts, or two types rather. There's postmenopausal osteoporosis, which is what we've just talked about, and that's called type 1 osteoporosis. And then there's what's called senile osteoporosis, and that's called type 2 osteoporosis. So both of these are primary osteoporosis. One obviously happens only in women, and then senile osteoporosis happens in both males and females. I'm sorry. And so I'm going to have a slide on this, and then we'll have a slide on this. So the slide on postmenopausal osteoporosis is this one. And there's a decrease in the serum estrogen, and that results in an increase in osteoclastic activity. That's what we saw in that illustration a minute ago. So in contrast, the osteoblastic activity seems to remain stable. So in postmenopausal osteoporosis, it's an increase in osteoclasts. And I don't think that this is particularly important, but I put it in here. There's a disproportionate loss of the cancellous bone versus cortical bone, and therefore femoral neck fractures, vertebral body fractures, and distal radius fractures are more common in women who've gone through menopause. All right, so this is the slide on senile osteoporosis, and as I said before, it's also called type 2 osteoporosis. So in senile osteoporosis, there is a decrease in osteoblastic activity. So these osteoblasts are senile, they're old and tired, and they don't put down as much bone. And again, I don't think this is particularly important, but just for completeness sake, in senile osteoporosis, there's a proportionate loss of cancellous and cortical bone in the elderly. Then there's what we call secondary osteoporosis. This is also called type 3 osteoporosis. And all these numbers tend to get confusing to me. And we'll have a slide in a minute that'll summarize this. But in secondary osteoporosis, the osteoclasts are overly active, and therefore too much bone is resorbed. And there are many disease processes or conditions that are associated with secondary osteoporosis. So these are some of them. Endocrine disorders, hyperparathyroidism, which we'll talk about in a little while. We're not going to talk about hyperthyroidism or diabetes, but apparently diabetes alone tends to cause secondary osteoporosis. Rheumatoid disease, malabsorption syndromes, alcohol abuse, and we certainly see that some in in some of our patients. Long ago, I heard an orthopedist say that he went to medical school in Salt Lake City, Utah, where there are plenty of Mormons, and Mormons do not tend to drink alcohol. And he said he never saw an adult male with osteoporosis. And then he moved to some other part of the country where there was a lot of drinking, and he was impressed that he was seeing men, older men, obviously, but men with osteoporosis, and he thinks that it was because in that area of the country they were drinking a lot. Anyway, tobacco smoking tends to cause it. This is something I don't really know anything about, but patients who have HIV or AIDS, especially those who are on some of the antiretroviral drugs. And then I've definitely seen this, people who are on prednisone for various reasons, they tend to get osteoporosis. And then there are various cancers and hematologic disorders that can cause secondary osteoporosis. So let's review the terminology. There's type 1, type 2, and type 3. Type 1 and type 2, they're both what are called primary osteoporosis. The type 1 is in women, it's postmenopausal osteoporosis, and type 2 is the senile osteoporosis, and obviously that's seen in both males and females. And then type 3 is the secondary osteoporosis. That's osteoporosis that develops because there's some sort of underlying medical problem. And obviously it can involve both males and females. I prefer to use words rather than numbers because the numbers get kind of confusing. I tend to forget those. So with regards to the imaging studies for osteoporosis, I outlined 4. First of all, plain radiographs. Well, plain radiographs are not sensitive tests for osteoporosis, but many times the first evidence that someone has osteoporosis is because they've fallen and broken something, typically a hip, sometimes a wrist fracture. And the other, excuse me, the next study I'm going to talk about is the so-called DEXA scan, dual energy X-ray absorptiometry. And this is really the test that we should focus on. You can get a quantitative computerized tomography, a CT scan for assessment of osteoporosis. Maybe Dr. Humphrey uses that sometime. I'm not sure. I've never seen it used for the assessment of osteoporosis. It's probably much more expensive than getting a DEXA scan, and it involves radiation. And then there's a ultrasound of the calcaneus that can be used. And again, I've never seen that used myself. It may be used by some of the rheumatologists, but it's only a screening tool. Apparently it's not very expensive, but it should only be used as a screening tool. Once you start treating patients, you shouldn't use this as a tool to assess the effects of your treatment. If you're treating someone, you should get periodic DEXA scans. So again, plain radiographs, those are not sensitive tests. You need to lose at least 30% of bone mass in order to reliably see a decrease in the bone density. And I will point out that the endosteal osteoclasts resorb the cortices. In other words, the osteoclasts that are inside the bone along the cortex, they resorb bone along the cortex, and that tends to make our long bones wide. the canals rather. And as this is going on, in some patients, not all patients, but in some patients, the width of the bone gradually becomes wider. And then that results in a appearance that we call the stovepipe femur, which I'll get to in a minute. All right, so the x-ray of the patient on the left is a 57-year-old who does not have osteoporosis, and you can see her cortices are thick, and therefore the canal is not particularly wide. The x-ray of the other patient's an 84-year-old with osteoporosis, and I think you can see quite clearly that the canal here is wider than the canal there. And again, the width of the bone tends to gradually increase. So because osteoblasts are putting down new bone here, even though osteoclasts are resorbing the bone here. So the bone from here to here can become wider than it was previously. So the canal is wide and the width of the bone is wide. So that's what leads to what we call a stovepipe femur. So what does that mean? So the radiographs of the proximal femur of a patient with severe osteoporosis kind of look like a stovepipe. So here's the stove, and the smoke is going up the stove, and you want the pipe to be wide so that it can easily go out, the smoke can easily go out the pipe rather than coming out into the room. Smoke doesn't create a lot of pressure, at least not in this sort of a situation, so the walls of the stovepipe can be thin. I don't have a stovepipe to demonstrate that. So what's the other option? What do you call a normal femur? So at least in a young patient, we sometimes use the term champagne flute femur. So, and I do have an illustration or a prop here. So here you have a canal that becomes maybe wide up at the top, and then it becomes tapered. So this is what we call this is not a champagne glass. I think this is a regular wine glass. But anyway, so you may hear the term a champagne flute femur as opposed to the stovepipe femur. So again, here's the stovepipe femur, wider than normal overall, and the canal is wider. And this may not be a classic champagne flute femur, because this is a 57-year-old lady rather than a 17-year-old kid, but this would be described as a champagne flute femur as opposed to a stovepipe. But but remember, plain radiographs are not sensitive tests for diagnosis of osteoporosis. This is the test that you should use, the dual energy absorptiometry. It's a very reliable means of quantitating bone loss, and this is the most commonly used tool for diagnosis of osteoporosis and osteopenia, and that's a term we'll get to in the next slide. And as I said before, this test, the DEXA scan, is the test that can be used not only for screening, but also for assessment of the effect of the ongoing treatment. So what's osteopenia? This is basically just a term meaning that the bone has lost some mass, but not to the degree seen in osteoporosis. So this is the technical definition on a DEXA scan, a so-called T-score of +1 to -1 is normal. T-score of -1 to -2.5 is what we call osteopenia, and a t-score of minus 2.5 or less, in other words, 2.6 or 2.7, that's the criteria for the diagnosis of osteoporosis. Here's another pop quiz. Okay, true or false? Osteomalacia is another term for osteoporosis. That's false. Osteoporosis means porous bone, whereas osteomalacia means soft bone. And I'm not an ear, nose, and throat surgeon, but I know that there's a term called tracheomalacia, meaning that the trachea is soft. So, and remember, osteo is from a Greek word, osteon, meaning bone. So osteoporosis means porous bone. Osteomalacia means soft bone. Osteomalacia is usually a vitamin D problem. And to cover osteomalacia in depth, we need to talk more about vitamin D. So here's some basic information. Vitamin D actually shouldn't be called a vitamin because it's not a vitamin. It's a hormone rather than a vitamin. By definition, a vitamin is something that you have to consume in your diet. And it turns out that vitamin D is actually something that we make. So we shouldn't call it a vitamin, but we've been calling it a vitamin for so long, I'm sure that's not going to change. So vitamin D is vital for the absorption of calcium and phosphorus from our diets. Vitamin D deficiency is common. Vitamin D, and again, it's actually a hormone, but it's synthesized in 3 steps. So, yeah. Okay, so these are the 3 steps in the synthesis of vitamin D, which is also called calcitriol. And this gets a little confusing because calcitriol sounds kind of like calcitonin. Those are 2 very different things. So calcitriol is synthesized in the body in 3 different steps. First of all, our skin, when exposed to sunlight, creates this thing called cholecalciferol. And then the cholecalciferol goes to the liver and it converts it to this thing, 25-hydroxycholecalciferol, also written down as 25 vitamin D, also called calcifediol. I can't ever remember these terms. I just remember it's cholecalciferol, and then it becomes 25 vitamin D, and then the 25 vitamin D goes to the kidneys, where it's converted to the 125 vitamin D, or more simply, just calciferol. Excuse me, calcitriol, my mistake. So what can lead to a vitamin D deficiency? One thing is inadequate sunlight. As I said before, as we get older, we tend to spend less time out in the sunlight. In addition, if you're trying to protect your skin from the effects of sunlight, you wear a cap, you use sunscreen like I do, trying to prevent myself from getting another basal cell cancer. That decreases the effect of the UVB light. So if you're not spending enough time in the sun, then you're not getting as much effective, you're not starting the synthesis of vitamin D. And then in the liver, various disorders can impair the conversion of the cholecalciferol to what we call 25 vitamin D. And then various kidney disorders can impair the conversion of 25 vitamin D to 125 vitamin D. So it can be a skin, liver, or kidney problem. All right, so of note, vitamin D, which we probably should call calcitriol, it's fat soluble, as are vitamins A, D, E, and K. And therefore, if we don't synthesize enough of it, or if we're not absorbing enough of it from our diet, there's not going to be an immediate effect because we, tend to carry lots of vitamin D in our fat stores. So the pathophysiologic effect is going to be delayed. In the United States, vitamin D a vitamin D deficiency is common, even though they add it to some of our food products. For example, milk has vitamin D added to it. I don't know if they do that in Ukraine or not. And then, of course, a lot of people, including me, take vitamin D supplements because, again, I try to avoid sunlight because I don't want to develop another basal cell skin cancer like I got on my nose. So remember, it's a three-step process. First in the skin, second in the liver, and then the third in the kidneys. Problems with any of these steps can lead to what we call osteomalacia in adults, the same basic problem we call rickets in children. Obviously, problems that develop during childhood can have different manifestations than it has, than it has in adults, because it can affect the bones as they're growing. So with regards to osteomalacia, the bones are soft due to poor mineralization. And again, in osteomalacia, the mineral to osteoid ratio is decreased. That's not true in osteoporosis, but it is true in rickets and osteomalacia. So we should think of osteomalacia or rickets as having two fundamental causes. There's insufficient absorption of calcium from the small intestine, but there can also be renal loss of phosphate. So what might cause a deficiency of calcium absorption? The deficiency of vitamin D is the most common cause of osteomalacia. We need to remember that vitamin D is necessary for us to absorb calcium from our intestinal tract. But a deficiency of calcium itself can cause osteomalacia. So even if you have plenty of vitamin D, if you don't have enough calcium in your diet, you can develop osteomalacia. So with regards to deficiency of vitamin D, that is the most common cause of osteomalacia. This is what was on that previous slide. So we can have an insufficient amount of vitamin D synthesis, or we can have an insufficient amount of vitamin D in our diet, or we might have an adequate amount of vitamin D in our diet, but if we can't absorb it, then we can still develop a deficiency of vitamin D. So again, it's kind of confusing because vitamin D, it's something that we ideally should be able to produce and not need it to be in our diet whatsoever. But many of us don't produce enough vitamin D, especially those of us who work indoors. And if you don't have enough vitamin D that you're making, then you need it in your diet. And if you don't get enough of it in your diet, then it can be a problem. Or if for whatever reason your intestinal tract doesn't absorb vitamin D, that can be another problem. But again, a deficiency of calcium itself can cause osteomalacia. So dietary insufficiency of calcium is a problem. I tend to drink plenty of milk, so I don't think I have a deficiency of calcium in my diet, but some people might not be able to absorb the calcium. So that's basically an overview of the problems of vitamin D and calcium insufficiency. So what's it look like? So this is, I don't know how old this patient is, doesn't really look like a child, but again, if someone has one of these problems as a child, we call it rickets. And in the children, it can cause bow legs. And this, again, this patient looks like he's not a child, but looks like he probably had this developed during childhood, and then obviously it does not self-correct. So bow legs, and then very wide growth plates, wide growth plates. This patient, obviously as a child, has extremely wide growth plates. You don't even see the epiphyses. So this is a dramatic example of rickets. Here's basically the same problem, and on this one you can see that it's not nearly as dramatic, but you can see that there's a problem here. This just does not look normal. And again, in children, if they develop this problem, we call it rickets, and it can develop into bow legs. In adults, it looks different because if someone has developed normal growth of their bones, then they're during childhood, obviously. And if they develop one of these problems with vitamin D deficiency or calcium deficiency, then they're not going to develop bow legs because their legs have already developed. But you can see it in adults, and I probably have seen some cases of osteomalacia and didn't really recognize it. I just assumed that if the bone wasn't very dense, it was in an older person, it was osteoporosis. My guess is that I've missed some cases of osteomalacia. So here is a classic case, long-term nursing home resident who's weak and has diffuse bone pain. You should think of that person as having osteomalacia, especially if radiographs show insufficiency fractures of the pelvis and femoral necks. So you can see here that this looks like a fracture that developed in the past and is healed. And you can see right there an incomplete fracture of the femoral neck. So now we'll move on to Paget's disease of bone, also called osteitis deformans. It's a remodeling disease which happens, when it happens, the bones can become fragile and gradually misshapen. Common sites are pelvis, skull, spine, femur, and tibia. No one knows exactly why it happens. It's a common problem. Supposedly, at least 1% of adults in the United States has some degree of Paget's disease of bone, but most cases are asymptomatic. Risk factors include Anglo-Saxon ancestry and being over age 40 and having a positive family history for it. The problem is the repetitive cycles of breaking down and building up bone. And classically, it results in weak and deformed bones. There's a risk for some reason of it developing into a osteosarcoma. And one of my mentors, when I was an orthopedic resident, many years later developed osteosarcoma of his pelvis, and I was told that he had underlying Paget's disease. The treatment is to inhibit the osteoclast, so try to decrease the breaking down of the bone. So here's an X-ray of a pelvis. You can see on the left side how the bone just doesn't look normal, doesn't look like this. And even if even if you didn't have the normal side to compare with. Even if you were looking at this, I'm sure you would think this just doesn't look normal. And if it develops in a tibia, it can gradually cause a bowing of the bone. This is a lateral x-ray of the tibia. Now we're going to talk about hyperparathyroidism. There's basically two ways to, or two groups of patients with hyperparathyroidism. Those who have primary hyperparathyroidism, that means that the problem is in the parathyroid glands themselves. That's the primary source of the problem. So the parathyroid glands secrete an excessive amount of parathormone, also called parathyroid hormone, or PTH. So there's no outside stimulus. This is just a problem in the parathyroid glands themselves. In secondary hyperparathyroidism, the primary problem lies somewhere else in these glands. And 2 weeks ago, I said that they are small, stupid, and lazy, but that's not always the case. But these stupid glands are the secondary problem. They just do what they're told to do. So if some other part of the body is telling them to produce too much parathormone, then they do it. So they're not very smart. So the underlying pathology stimulates the parathyroid glands to stimulate an excessive amount of PTH. So again, it turns out that these little glands aren't always lazy. Sometimes they work too hard. So in primary hyperparathyroidism, the cause can either be a parathyroid tumor or hyperplasia of one or more of the 4 parathyroid glands. So again, the pathophysiology is that too much parathormone stimulates the osteoclast to absorb too much bone, so that the net effect is that there's a loss of bone, and it can be either widespread or very focal. So this is pretty widespread effect of hyperparathyroidism. This is what's called the salt and pepper appearance of the skull. And here's another example of diffuse effects of hyperparathyroidism. All of these phalanges look abnormal. But in some patients, for some reason, the effect is much more localized. And you can see that the bone has been markedly resorbed here and also resorbed there. But the shaft itself doesn't really look like it's very much affected. So that's what's called a brown tumor of hyperparathyroidism. So secondary hyperparathyroidism is a very complicated problem. If someone has some sort of a disorder that's causing the parathyroid hormones to be stimulated to produce excess amount of parathormone, you need to call an endocrinologist, because it's extremely complicated, or it can be. I will say that I've never seen, to my knowledge, a patient who had secondary hyperparathyroidism. In fact, I'm not sure I've seen anyone who had primary hyperparathyroidism either. I have seen, this was many years ago, I saw a patient, or treated a patient, who had this really bizarre type of superficial tumor. It was basically a skin tumor, and that tumor did not stimulate the parathyroid glands to produce excess parathyroid hormone, but instead the tumor itself produced parathormone. And so he was sent to me by one of the endocrinologists to excise this tumor, which was a rather small tumor, and it was very superficial. And once I took it out, then his problem went away, at least the period of time that I heard about it. And I can't remember now what that name of that tumor was, but anyway, that's the closest I've seen to someone who had any type of hyperparathyroidism. Okay, so questions. I told Dr. Matvienko that if there are any real serious questions about any of this, we would need to consult with an endocrinologist. And unfortunately, I don't have an endocrinologist sitting here with me. But I have a question for you. Do you all recall seeing anyone who had hyperparathyroidism or Paget's disease? Maria, have you ever seen anyone with Paget's?
We have question from Nadia Barabash. Yes, if
Maria Sergeyevna, about Paget, about Paget disease or hyperparathyroidism, I'm endocrinologist, and I have some questions with hyperparathyroidism, but fortunately, without osteoporosis with fractures. So osteopenia or treated osteoporosis, so they are quite compensated.
Okay, well, that's good.
And if I understood, Dr. Schofield also answer on your question, should DEXA gives a much more quantitative result than ultrasound, while is qualitative? It's
Okay,
maybe answered, yeah. Dr. Schofield is endocrinologist, yes? Is it true, John? Yes. Thank you. So we had a question. We have question and answer on this question. Thank you. And maybe somebody has question.
Well, as a surgeon, I've treated many patients with osteoporosis. I've probably treated at least some patients with osteomalacia, and I assume that it was osteoporosis. You know, from a surgical standpoint, if someone has a broken hip, you're going to treat it the same. So I can't say that it was a problem that I misdiagnosed someone with who has osteomalacia as being someone with osteoporosis, but anyway, it's not ideal to think that someone has osteoporosis when the real problem is osteomalacia.
Dr. Tompkins, please, I have question. Osteoporosis is a main cause of fractures, yes, no, for some category for patients. And what is your approach for pre-operative support of this patient with osteoporosis, and how it affect of a result of surgical treatment?
Well, in some patients with osteoporosis, their bone is so soft that our fixation devices or plate and screws, they just don't fix the fracture as solidly as we would like. And in general, this is a broad statement, in general, intramedullary fixation is preferable to plate fixation. So in general, it's better to have something inside the bone to fix it rather than on the surface of the bone to fix it. I remember seeing one patient many years ago. He actually had renal osteodystrophy, and he had extremely weak bones, and he just sat down on the toilet and had non-displaced femoral neck fractures of both hips. And I put screws in both hips, but his bone was so soft that the threads of the screws, I don't think, really got very much fixation. What we call, we didn't get very good purchase is the term that we use. It doesn't, we usually think of purchase meaning buying something, like you go to the store to purchase food. But in this case, purchase means a bite in the bone. So I put these screws in him, but his bone was so soft, I think that the screws basically were just spinning around without getting a grip on the bone. So, what should I say? Basically, the softer the bone, the more concern you have that your fixation won't heal. But in general, if you can use intramedullary fixation for a hip fracture, I think that usually the fixation is adequate. I haven't seen very many patients who failed to heal a fracture with intramedullary fixation of hip fractures, but it can happen. And then there are other factors involved. Osteoporosis does not seem to really inhibit the healing of bone. It just makes the bone soft to begin with.
Thank you. And the question, what is the middle age of your patient who suffer from these pathological fractures and osteoporosis? It's interesting.
I've seen many patients with osteoporotic hip fractures over the years. I would say that most of them are probably in their 70s or 80s. It's not very common to see osteoporosis in people who are in their 50s. You start to see it in people in their 60s. You definitely see it in patients who are in their 70s and older.
Thank you. More questions?
May I ask
Please.
First of all, I want to add that in Ukraine, when as an endocrinologist, I'm an endocrinologist, was an endocrinologist, and when we have the patient with secondary hyperparathyroidism, first of all, we exclude the pathology of gastrointestinal tract and kidney. And because secondary hyperparathyroidism is often the result of chronic kidney disease and malabsorption. But in our practice, we had young men who had osteoporosis, and we exclude any causes of osteoporosis. And so secondary and hereditary pathology. And what do you think? What could be the cause of osteoporosis in this situation in young men? Without any cause, we can't identify the cause of osteoporosis in this situation.
Okay, and it's not osteomalacia, it's osteoporosis.
Osteoporosis. We confirmed the presence of osteoporosis, but we couldn't find the cause of osteoporosis.
John, this is Hal Schofield.
Hello.
I might add, in a young man or even an older man, in which there's no other explanation, we would always look for hypogonadism. So inadequate testosterone could cause osteoporosis in a middle-aged man. So hypogonadism, I think, is a possible cause in that patient.
Thank you.
And what about alcoholism?
No, they didn't use alcohol.
Okay.
It's definitely another cause, though. Yeah.
Thank you.
And we have a question in chat. Could obesity provide osteoporosis from our student, Chris Landau? John?
I'm sorry, would you repeat that?
Last question in our chat. Could obesity provide osteoporosis?
I still didn't understand it. Would
Obesity.
Connection.
Oh, obesity.
Obesity. Yeah. Could obesity provide osteoporosis?
I've never heard of obesity causing osteoporosis. I think that it tends to be the opposite. And whether that's because patients who are overweight are just stressing their bones and basically exercising their bones more, I don't know. But it becomes very complicated because we now know that fat is not just dormant tissue, that it has some sort of hormonal things that are going on with it. So I don't think that obesity ever causes osteoporosis. It may serve to protect some patients from osteoporosis. Is that true, Hal?
Yeah, I think it definitely protects women against osteoporosis, and that may be a mechanical thing that you have more exercise, as you say, is a good enough word. But also you have production of estrone in fat, and that may protect women. Even postmenopausally, the amount of estrone that's produced in fat may protect women from osteoporosis. Obese men, though, with enough estrone production may become hypogonadal because that feeds back to the pituitary. And so you might have some hypogonadism that's mostly obesity related in men that could worsen osteoporosis in men. But in women, it's definitely protective.
Huh, that's interesting. I had not thought about hypogonadism. Well, all of this becomes very complicated, and I don't even understand where some of these things or how they interrelate, like the renal osteodystrophy. It becomes so complicated that I can't ever keep it straight. In fact, I'm not sure I ever get it straight. Hal, is the term renal osteodystrophy used? Recently, there was a lecture on kidney replacement therapy. I didn't even know what that term meant, but Dr. Duke, one of our young nephrologists, said that it used to be called renal replacement therapy, and then they changed it to kidney replacement therapy just because apparently they thought that lay people would understand the word kidney better than renal. But anyway, so do we now call it kidney osteodystrophy, or is there a different term?
I think I still hear people saying renal osteodystrophy. Yeah. And it's certainly it's parathyroid hormone and decreased production of 125 dihydroxyvitamin D, which affects osteoclast, and they make a fibroblast growth factor 23, which circulates back to the kidneys. It's a hormone made by osteoclasts and really tells the kidney what to do with phosphorus and calcium, and so that leads to the hyperphosphatemia and the low calcium. So it's it's a complicated. Just all that's just been figured out in the last 10 years or so. The fibroblast growth factor 23 and how vitamin D affects osteoclasts. It's just being worked out in the last few years.
Okay. All right. Well, it's it's the top of the hour. So if there aren't any other questions, we will end this lecture. And I'm hoping that that Adam Zabinski can give a lecture on a pulmonary subject again next week. But so far he hasn't sent. What's that?
Do you ask about next lecture? Yes, you propose Adam Przebinda with one of his lecture.
Right, but I'm not sure which lectures he has prepared for next week. But
maybe Adam already has some prepared lecture and he could propose. It will be simpler for him.
Right. So I asked him yesterday to send a list of the lectures that he has, but as of this morning, I hadn't received a reply. And on the 19th, I think it's the 19th of December, Jennifer McGowan said that she would potentially be available to give another lecture. Yeah, Thursday the 19th, but she said that she's traveling on the 18th, and if she has a problem with her airline flight, she might suddenly become unavailable to lecture on the 19th. So I don't think we should plan on her talking about her frostbite. Excuse me. Accidental hypothermia again. The other thing that she would like to lecture on, I think, is frostbite injuries. She had time to barely mention frostbite as being a problem in patients with hypothermia. You know, that those are related problems, but obviously they're not the same problem. You can have frostbite without hypothermia treatment, and you can have, you know, hypothermia patients who don't get frostbite. But anyway, she would like to talk about frostbite at some point.
Okay, so we had two lectures. Next lecture, Adam Przebinda, and he decide the topic of this lecture. And after the next time, about frostbites. Is it correct?
That's what I'm hoping. Okay.
No, of course. We plan and of course. Okay, thank you.
Yeah. And one other thing, I mentioned this lady last week, a lady named Alexandra Los, L-O-S. She's a neurologist here. I guess she's a relatively new neurologist to the university campus. So I'm hoping to talk with her on the phone on Monday with Andrei Yabluchansky. I plan to go over to his office. He knows her quite well. And so I'm hoping to go over to his office on Monday morning around mid-morning. And then he and I will call her and he can tell her about the lecture series that we have, and hopefully she can tell us what lectures she might have available for neurology.
Okay, so we will plan our neurology lectures, of course, in the next semester. Is it correct?
Right.
Okay. Yeah, thank you. It's very very good plan, actually. So next 2 weeks we have potential lectures, and of course we need to organize some meeting with you, and maybe some who want to decide and make plan of the new semester.
Right.
Maybe with Yablochanski.
Yes. Okay.
Mhm.
All right. Well, I will hopefully see you next Thursday morning with Adam.
Yes, thank you. And our auditor say you thank you. It was interesting. It was and we had very active discussion and new information. Thank you. And thank you for your opinion or for your experience.